Good afternoon, everyone, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are in a listen-only mode. For those that are connected by telephone requiring operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Maria Judd, Vice President at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Hello and welcome everyone to today's webinar, which is part of a series being hosted by the Canadian Northern Remote Health Network's Virtual Learning Exchange. I'm Maria and I'm a Vice President with the recently amalgamated organization which has brought together the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. And before we begin, I'd like to recognize that we are gathering from a variety of places across the country, many of us working from home, and many people very involved in the response and the ongoing impacts of the pandemic. So I really appreciate you joining us today and look forward to our discussion. I also want to recognize that the main offices of our amalgamated organization, CFHI and CPSI, are located on the traditional unceded territory of the Algonquin Anishinaabe and Treaty 6. At this time, I'd like to invite you, if you haven't already, to introduce yourself using the chat feature. And if you're comfortable, to also include a reflection of the traditional territory that you're joining us from. As I've been learning, a traditional land acknowledgement is an act of reconciliation that involves making a statement that recognizes the traditional territory of Indigenous peoples who have called land home since the beginning. I'd also like to recognize that we're being joined behind the scenes by my colleagues, staff of the Northern Indigenous Health Team, Despina Papadopoulos and Megan Sabian. A huge thanks to them for helping to organize today. They'll be operating our chat box today, and we really hope that you'll share your reflections and questions as we go through our time, starting at the beginning. I'd also like to thank the members of the Virtual Learning Exchange Working Group who are participating in today's event. Thank you for your guidance in shaping today. Often it's hard when we're gathering virtually to know sort of who's in the virtual room with us. So I'm pleased to share with you that we have a really diverse group of individuals joining us today from coast to coast. The majority of our participants who are registered are coming from Newfoundland, Ontario, Saskatchewan, British Columbia, Yukon, and the Territories. And you've shared with us that you have many different roles, you wear many different hats, come from different sectors, including administrators, consultants, physicians, nurses, researchers, policy advisors, QI specialists, patient and family advisors, persons with lived experience, and Indigenous leaders. So thank you for joining. It's really the diversity of perspectives that we bring together that we know will help create an opportunity for really shared learning, reflection, and how we go forward together from here. We're pleased to let you know that we're offering this webinar bilingually. So if you'd like to view today's slides in French, please let us know using the chat box on the screen. And we invite you to use either official language when entering your questions or your comments throughout today's session. And a final reminder that today's session will be recorded and made available on our website. I'm really pleased to be joined today and very grateful to be joined today by my co-host, Charlene Lafreniere, who's the Chief Indigenous Health Officer with Manitoba's Northern Regional Health Authority. And she'll lead us through some reflections and discussion, drawing from her own experiences with enhancing equity and access. Charlene, thanks so much for collaborating with us to deliver today's event. And I'll hand over to you to introduce yourself and to welcome our participants.
Thank you very much, Maria, for the opening and for the introduction. Like Maria said, my name is Charlene Lafreniere. I'm the Chief Indigenous Health Officer with the Northern Regional Health Authority in Manitoba. And thank you to all the participants who've logged in here with us to hear. I, of course, got a sneak peek to some of the information that we're about to hear, and it's really exciting. So thank you for joining in, and, of course, those who have a full schedule at the time and are clicking in at a later date, so much appreciated. Just a little bit about myself. I'm based in Thompson, Manitoba, which is in the traditional territory of the Nishawasset Cree Nation, Treaty 5, and the homelands of the Métis. I'm very proud to be here. I am from the Métis Nation and proud to be a Canadian Indigenous woman working in healthcare and having a responsibility to influence equity, accessibility, and cultural safety in our region. And it's been a real privilege in furthering those partnerships and engagement that are required to improve healthcare, and exciting to work alongside people like Julie and Harsasil, and just meeting Dr. Mendez, but to work alongside professionals who ensure that those of us who are engaging and partnering have real solid work that we're promoting, and knowing that the work is being done in a good way for our community's patients and our partners. So thank you for the opportunity to be a part of the working group, to be a co-host in today's session, and I just welcome to everyone for being here with us. Thank you.
Thanks so much, Charlene. I really appreciate you collaborating with us on this event, leading up to and including today. We're delighted to be joined by your colleagues from Northern Regional Health Authority, Dr. Singh, the Medical Director for Primary Care Clinics, and Julie Jacobs, Director of Primary Care and Clinics. Really fortunate to have you with us, and I'd like to turn over to you to introduce yourselves and to welcome our audience.
Hi, so I'm Harsasil Singh. I'm the Medical Director of Primary Care Clinics for Northern Health Region. I'm also a family physician, and I'm actually living in Thompson, which is Treaty 5 territory, just as Charlene. We are in the same location. So I'm privileged to be here, and I'm really thankful for the host for arranging this event, and I pass it on to Julie Jacobs.
Hi there, my name is Julie Jacobs, and I'm the Director of Primary Care and Clinics and Home Care as well for the Northern Health Region, and I'm also located in Thompson, Manitoba, which is located in Treaty 5 territory. And I would just echo the words of Charlene, what a privilege it is to be part of this conversation today and to share our experience and have some learning along the way. So thank you very much.
Thanks so much, both. We are also joined by Dr. Ivor Mendez today, who's joining us remotely from Bolivia, as he's partaking in a humanitarian effort during this pandemic. And he's been appointed the Fred H. Wigmore Professor and Provincial Head in the Department of Surgery at the University of Saskatchewan and the Saskatchewan Health Authority. And Dr. Mendez, would you like to introduce yourself and welcome our group today?
Thank you so much. It is really a privilege and an honor to participate in this webinar. As you know, we are in a very special time in our lives as we face the COVID pandemic. I am a neurosurgeon, and as you said, I'm the provincial head of surgery. I've been involved in virtual care for almost for a decade. And this work has been basically focused on rural and remote locations, and specifically in underserviced populations like the indigenous population and the most vulnerable individuals, the children, pregnant women, and the elderly. So I'm looking really forward to the webinar to hear what my colleagues have to say and to discuss the current status of virtual care in the future.
Well, thank you so much for joining us. Just before we dive into the discussion, I wanted to share a little bit about how we came to today's session and this virtual learning exchange. And that's really from hearing from the members of our Canadian Northern and Remote Health Network. We started gathering, actually we had a roundtable virtually in May, and identified a shared interest in really doing some deep dive discussions and learning and knowledge exchange in the area of virtual primary care, specifically in northern and remote settings. And today's session, I think, reflects the interest in virtual care and the opportunity to improve access and the quality of primary care even before the pandemic. And of course, that rapid shift and increase in virtual care we're experiencing during the pandemic. So a huge thanks again to the network for their help in shaping and planning today's session. I know many of you are online. Today's session is a second session in a series of 3. We held our first one in November, and the recording is available on our website, and we really focused on important considerations for cultural safety and Indigenous partnerships, through the lens of virtual primary care, and we heard from colleagues at the First Nations Health Authority in BC. And today we're focusing on enhancing equity and access, and later in March we'll do a deeper dive into how do we support meaningful patient-centered care and partnerships in a virtual space. So today we're focusing really, our two objectives are one, enhancing equity and access in virtual primary care, and then secondly, looking at opportunities and challenges that have emerged with virtual primary care and how we can enable that continuity of care regardless of location. So there's three parts to our time today. First, we'll hear from Dr. Singh and Julie, who will share their story of bringing virtual primary care services to remote areas through working with community and building trust and relationships, including in the context of our current pandemic. Then we'll also hear from Dr. Ira Mendez, who will walk us through his journey in developing and delivering technology-led and assisted primary care that's allowing for patients in northern and remote communities to receive timely care alongside their families and in their community. And then part two, Charlene will be alongside me virtually, and she'll offer her guided reflections throughout our time together, and as a part of her role and her experience as Chief Indigenous Officer with the Northern Regional Health Authority in Manitoba. And then, although you're welcome to offer questions and reflections in the chat throughout our time, part three of our time today is really that opportunity to have an open dialogue, for you to ask questions, provide comments, share your experiences. So we encourage you to start sharing now and throughout, but we'll make sure we have dedicated time to really respond to and facilitate a dialogue using chat at the end of our session. So at this point in time, I'm pleased to hand over to Dr. Singh and Julie to share their story. Over to you.
Thank you so much. So we are going to just talk through a little bit in very high level, because we only have 15 minutes, our experience of really the past year and COVID as the catalyst for how we expand our virtual technology to provide primary care services throughout the North. So just as a start for a frame of reference, I just wanted to highlight our geographic region and really where we're located. So this is the province of Manitoba, obviously, and the top half of the province, the whole yellow section, for the most part constitutes the northern region. The point that I wanted to highlight here is that we do within our health region have a number of jurisdictional divisions, both federal, provincial, Northern Affairs communities, which of note, not all of those communities fall under the purview of the Northern Health Authority in terms of primary care provision. So, so there's certainly some pre-existing and long-standing challenges and jurisdictional challenges that we do face, but I think just important for the frame of reference of this conversation today that our scope is not the entire region at this point, although there's certainly some good learnings and go forward actions that have come from our experience so far. So again, just to lay a little bit of the pre-COVID context. So prior to COVID really encouraging us to explore our virtual technology, our primary care in our region is largely offered by inpatient appointments, or in-person appointments rather, which, given the geography of our region and many of our communities are physically at quite a significant distance away, it requires our providers to travel often long distances to our outlying communities, which has its own challenges. We do have some technology pre-existing, so we have a regional EMR. We use the Accuro electronic health record. And in our region, most of our regional sites are connected through that EMR, which certainly has its benefits for communication and information sharing. But again, important to note, in our region, we suffer some quite significant connectivity challenges. And again, back to the jurisdictional differences, that many of our First Nation communities do not have either connectivity or access to our regional EMR. So certainly some challenges with that. We also have some virtual technology, again, that we have used. So telehealth is probably, or was probably, the most common technology that we've used. We also have e-consult, which is a standardized referral pathway that's been used. But again, both of those technologies were used more as an ad hoc basis, optional. And in some cases, our telehealth technology requires travel on behalf of the patient to access that. We also have a provincial electronic record, our eChart system, which has access to some primary care information, our DPIN, which is the drug history, different results, and diagnostics that the patients have accessed. And that was really largely the extent of our virtual care prior to COVID. So I'll turn it over to Dr. Singh to talk a little bit about what's happened since, and again, really COVID as the catalyst.
Yes. So again, as Julie mentioned, like pre-COVID times, we didn't have much in terms of virtual care as an option for patient care. But when COVID happened, and we were looking at expanding virtual care regardless, but COVID was the catalyst that resulted in rapid expansion of the virtual care models, because we had to reduce in-person care to comply with the public health guidelines that were throughout the province and most of the country. So it was also in the beginning, we did have issues related to PPE supply, so we couldn't see all the patients in person because we did not have enough masks and N95 gowns and gloves. So although that stabilized a little bit, we did continue to have like challenges with the waiting area and also with the staff because some of the staff were redeployed to other areas where there was no more need for helping COVID patients. So because access historically was defined by in-person appointments, so the only way you have seen a primary care provider in the past was if you had a physical appointment in a healthcare facility. So we had to change this because we couldn't provide in-person care as much as we did in the past. So this would have led to delay in care and people presenting to ER. So the only virtual care option we pretty much had in the past was telehealth. Because that was one that was like kind of under funding as well, like a funding agreement. But even telehealth requires you to go to a facility to receive the care. So you can't get like telehealth in your home, for example. So you're still defeating the purpose of keeping people home, which is what we needed to do as per public health. So so we did actually expand on tariffs in Manitoba on virtual care, which actually helped quite a bit. So then we started doing more phone appointments. So that was our first mode of virtual care. And in spring of last year, 2020, we actually even worked on implementing Microsoft Teams as another method of patient appointments. And we are still working on improving it. We haven't still found the real purpose where to use this technology as well. But the phone appointments is pretty much like a backbone that we started doing. And another thing we also needed to work on was to clarify what can be booked virtually versus in person, because we have to maintain patient safety, because not everything can be done virtually. But we were surprised to see a lot can be done virtually, which we never thought of before. So, and by virtual at this point, I mostly mean phone appointments. So we did, but to help with the in-person assessments, we created a model in Thompson Clinic, where I primarily work, is an overflow clinic. So what that meant is like whenever anybody needed an in-person assessment, they were booked with this overflow clinic. But these patients had a prior virtual visit in which their issues were prioritized. So it would be a quick in-person visit. And also we did try to like sit together and figure out how can we improve virtual care, knowing that there was not much information out there. So what we started to do is we sat down and discussed some actual case presentations that went to this overflow clinic. And then we thought, like, what could we have done differently and avoided this physical visit and try to like meet the provincial target of keeping most patients at home and not bringing them in the facility. So we also did like multiple choice questions, and the practitioners would choose the best answer. And it was surprising, like most people were choosing virtual care as a possible option to treat these patients. So that was one way we made this work. And also we did some process shifts. So we did like make sure patients were able to do their lab work. We were able to mail the requisitions to their home. We could fax them to our lab, or now we can even like email them to patients who can print them at home and take it to the lab. So also if people we tried to call patients and they missed their phone call, we had like defined processes how we can get back to them. And we also did like lots of communication with providers and public. So that was like all of the work that did happen as the evolution of virtual care went on. And I'll pass on to Julie to talk about access and equity.
So just to summarize, really as COVID happened, there was a significant amount of work that came with in regards to virtual care and really implementing that quickly. Our priority along the way was really how do we maintain access throughout that journey, recognizing patients' needs don't stop despite a pandemic. And so through that work, as Dr. Singh mentioned, we began with phone appointments because it was the most accessible technology that we had, and the time frame that we were up against, it made the most sense. We have implemented others options since then, but it's been a lot of work. And so throughout the past year, our focus has really been on the process work and making sure that we have patient flow and communication, as it's been a lot of change all at once. When we think about access, just for a reference point, in our region we monitor access using the advanced access methodology. So we look at third next available, for those of you who are familiar with that, as our reference point for access to care. So pre-COVID, the median in our region was over 20 days. And what was interesting with our journey through virtual care and through pandemic was that despite the fact that the demand did not change, which we also track, we saw a fairly significant reduction to about 14 days or less at most of our sites with the implementation of virtual care. And another layer of that in terms of no-shows is what we did see is that with the implementation of care, we actually saw a reduction of no-shows, which significantly increases our supply and has definitely impacted our access. And when we break that down even further, there's a notable difference between the no-show rates for in-person appointments versus no-shows. And the no-shows rates for virtual appointments is quite a bit less over the course of the last many months.
And another thing I also want to just mention under access is that we did manage like many medical conditions virtually. So we found that people were able to get the medical care they needed. And also it did result in reduction in travel for both patients and providers, making access to service easier. So like a lot of our times our providers had to travel down to like remote communities to provide care. And also we were able to increase the supply of providers, because lots of providers who did not travel in the past can now actually provide virtual care while they're because they're still available to see patients. And also we could preserve our capacity to deploy them to areas in need. Whenever there's a COVID outbreak in a community, we have some extra resource to send there now. And also it also showed, like as Julie mentioned, the no-shows went down, but also the client convenience, like people don't have to travel, but they don't have to miss work. Like they can be at work and you call them and they just take few minutes out of their work and can still attend the appointment. They don't have to find childcare. So that was another huge piece. And also we did e-consult service provincially that we were using before. We actually increased it significantly with this to be able to access our specialists much easier. So for example, in Thompson, we use e-consult as our default referral option now. So we send everything as an e-consult, and then based on the recommendation from specialist, it could be changed into a formal referral, which could be done virtually or in person. So, I will hand back to Julie to talk a little bit more about improving equity.
So when we think about equity, again, when we look at some of the value of adding and increasing some of the virtual technology in our region, again, it really did reduce the barriers, those geographic and transportation challenges that we do see in our region. So being able to offer appointments electronically definitely had the ability to bring care closer to home. We also saw with the improvements to access, it shifted our supply in a different way, where we were able then to reallocate resources potentially to areas that don't have that virtual access. So I think that was a really important takeaway for us, is that it's not a one-size-fit-all, and particularly where we have our connectivity challenges and infrastructure issues and jurisdictional issues that we're still working through. The ability to reshuffle resources so that we still are able to provide the service, but lean on that virtual technology where it is capable to be able to do that.
Mm-hmm. And another thing I also just want to mention is that the quality of care was less tied to specific location. So it didn't matter like where you lived, like if you were in a Bayline community or a First Nations community, you were still getting the same quality of care as you were getting in an urban central or like a larger center like Thompson, because you were still doing the same kind of virtual visit. We had access to EMR instead of going to those communities where we had no connectivity and were using paper charts. So the quality of care was suffering. Now we were actually providing equitable quality of care, like it doesn't matter where you're staying. And also the accessibility to other services also did not need to be tied to a specific location. Like I said earlier, like our primary care pool expanded now with virtual care. So I think we can move on to the next slide. So, Julie, I'll let you speak a little bit about the barriers and challenges that we faced.
So just to highlight, and I won't spend a lot of time on these, and I think these are probably familiar to anyone who's ventured into increasing virtual technology in their sites, but connectivity, again, is probably one of our biggest challenges in the North, just based on the infrastructure. I think also there's a tendency to underestimate the amount of setup and training and support that's required alongside an implementation, particularly the optics of technology. So sometimes there was a little bit of an assumption that we just turn it on and go, which certainly is not the case. And so, we have an excellent group of people who have worked very, very hard to pull this off in a very short amount of time, and we've got excellent providers and, who have really taken up the challenge of using new technology in a short frame of time, but it does require a lot of support and downtime procedures and all of that. Processes are sometimes cumbersome, so it's a really delicate balance between making everybody's life more difficult and actually improving service. So that was a lesson learned for us. Patient trust is something, I think, and this is a go forward for us as well in terms of the patient experience, but one of the things that was really difficult is how much information do you provide as it continues to change almost on the daily. And so when we don't have a solid grasp necessarily of how this looks or the things that need to change, or just shifting along the way trying to provide an accessible service, it's a delicate balance between providing the public with enough information so they know what we're doing and not having to change the story multiple times and losing that trust. So just something for us to reflect on. I think the time frame was a big challenge in terms of that and the pressures of COVID. There's certainly been some privacy considerations, so emailing and sending pictures and what to do with lab requisitions and the sort. Funding mechanisms, so I think Dr. Singh has already mentioned some of these in terms of the remuneration and the billing codes for virtual practice, so there's been some work on that and certainly more to come. There is the risk of losing the continuity of care, so we've really tried to keep that at the forefront in terms of maintaining that primary care relationship as a real core value as we've implemented virtual care, but how do you do that and navigate that smoothly? Timely access to technical support, again, We've talked about the communication and downtime procedures, and I'll just turn it over to Dr. Singh to talk a little bit about overcoming inertia, both mainly.
Okay, so
sorry, go ahead.
So thank you, Julie. So I think, yeah, we don't have much time left, so I'll rush through some of the slides. So actually, one thing was a big barrier was actually like to bring a culture change. Like how can we do virtual care effectively when it's like a new big change for most medical staff, like who haven't done this before. So actually, like we did like a sit down and kind of worked this out, and some of this happened organically. But we actually like used some principles of like influencer. If any of you are familiar with these 6 sources of influence, there's a book by Joseph Granny about like 3 pretty much like things we look at for motivation and ability. So personal, social, and structural. And we can make some changes in each of these boxes. And to actually get behavior change, we need to tick like at least 4 out of these 6 boxes, is what their like research has shown. So we can't just like reward people or demand accountability and expect them to do what we want them to do. So we have to like motivate them personally and make them able to do their job, like give them the skill. So these are like some of the examples, like what we did to actually bring the changes. Like we created a virtual care 2-pager where people could actually see like what is the reason behind it, like the why are we doing virtual care. But the second part of the 2-pager was actually the all the resources, like what can they do differently to see these patients virtually whenever they can. So it's like a quick resource. People can keep that on their desk, or we have like made an electronic version, like people could just access it whenever they need it. And we also gave people choice. We did a survey for preference of virtual work versus in-person work. So people who wanted to do some in-person work were not feeling left out, and they could choose. And interestingly, the results of the survey showed that 73% of all providers chose like virtual work as their first preference. So that did really help us to comply with the orders and actually make virtual care more a common mode of delivering care. And also we talked about like when and how to provide in-person care. So we defined like clear pathways and discussed like with all the providers. And also we did case discussion on actual presentations as a group, so which helped with the social motivation as well as ability. We gave them tools so they can learn from others. And structural, we did like by praising them when success was achieved, we rewarded them. And then also we reduced capacity for in-person appointments. So that was like changing the structure, so people did not have access to too many in-person appointments, because if you have too many of those available, people are just going to fill them up. So those were like some methods we used. So it was difficult. It's a complex challenge, so we needed like a really good way to overcome those challenges. So and the other thing, one more thing I want to just mention, and the behavioral change for virtual care is also now we need people to use more video calls. So we want them to move to Microsoft Teams. So now we are facing another inertia where people are becoming too comfortable with phone appointments and calling people in for in-person when needed, and forgetting about like another mode of delivery. So we are always overcoming some inertia when we are trying to like implement big change. So I'm just going to rush through the lessons learned quickly. That what we learned from virtual care is that we can provide care closer to home. So that's one thing. Then actually we did learn that patients don't want to travel, like despite the assumption of many of the patients who live in remote northern communities, oh, this is their opportunity to come out of their community and go to big centers. And that assumption was widely incorrect. People want to stay in their community and get the care there. So that was something we definitely learned during these times. And we also found that whatever we do has to be needs-based, like wrap it around the patient. So if it doesn't help the patient, then it's not as useful. So the care has to be safe, timely, and also we should be able to support reallocation of resources, like whenever needed. And also we need to support preferences for both patient and the provider. And as I said earlier, like we did a provider survey, and we also look at patient preference, like whether they want to be seen in person or be done virtually. And there was some financial benefit, we didn't have to travel as much, as well as we had our medical staff more available to work instead of spending time traveling. And also we did overcome inertia through I did present those slides on providers, but also with the system we needed virtual care tariffs. We needed to have integration between digital technologies and our healthcare system. So that was another inertia. And then clients, some reactions were mixed initially, and some felt that we were providing subpar care. And communication was very important, because initially when we didn't provide as much in-person care, people thought we were closed to business. So we had to advertise to the public that we are still open, but providing care in a different way. So I'll move it on to Julie for the next slide.
Okay, so I'll just sum up a few of these points. Some of this I think we've already mentioned, but just in terms of key opportunities and considerations for us moving forward and really evolving virtual care and primary care in our region is really probably first and foremost that continued engagement with First Nation communities and other service delivery organizations in the North, and how do we really bring our services together for the benefit of the patient in regards to equity and access. Certainly more patient involvement. So I think there was a question that had popped up perhaps about involvement of patients, and although in a perfect world I would love to say that we did that well, it was very much informal. It was often based on feedback that we hear in the community, or it was very ad hoc, I would have to say, just given the time and our resources, that we didn't have a great opportunity to really do fulsome engagement with patients. But that's definitely on our list going forward, to explore that patient experience and really tailor our services to that. There's huge opportunity for guidelines and standards and funding mechanisms and those sorts of things, not just at the regional level, but certainly provincially, and I would say nationally as well. So it's really opened up a different conversation. I think the technical support we really can't underestimate. So I don't know about other folks on the call, but sometimes the level of support for that clinical function isn't always as ideal as we would like. Creating structures that aren't one size fits all. So again, really maintaining that flexibility, that it doesn't have to look the same, and it can be rooted in the needs that are required, but also built to enable that flexibility both for providers and for patients. Evaluation mechanisms, again, would be one that we would highlight. For us in the North as well, one of the things that we did want to highlight was, although we found there was great value in being able to implement virtual care where it's possible and leverage some of those resources to be able to provide back into communities where that's not an option, is really making sure that in reality or optically or otherwise, that it's not seen as a reduction of service or a reduction of resources, because I think historically there's been a lot of loss of resources. There's been a lot of resources that are perhaps not equitably distributed. And so, the changes that we do have the ability through implementing increase in virtual technology, just making sure that we're not contributing to any fear of loss or inequitable redistribution. So that was, for us, a really key takeaway. And again, just ensuring that the technology doesn't further widen that equity gap. And also another interesting point just in discussing and reviewing and reflecting, making sure that we also are broadening our own definition of equity and access. So we have focused very much in our conversation about direct patient care, but also things perhaps like access to culturally competent care as an example, and really kind of breaking down that definition to be a bit more inclusive or a bit broader. So I think that sort of sums up our experience. I apologize, we've gone a bit over time.
No, thanks so much, both. And I'm just going to take a moment and turn to the chat because we've had some questions come in, and thanks, Julie, for already picking up on one of them, which was, was there an opportunity and how were patients involved in the design of some of the shifts towards virtual care? And I think just a couple of questions related to that. And Also invite folks to share in the chat if you've had experiences as well to share or resources. So a specific question was how much patient education or materials were developed or what supports were in place to support patients and families in that shift to virtual care. And then as a sub-question to that, were there opportunities to support ability issues, for example, hearing challenges?
Dr. Singer, do you want me to?
Yeah, so you can go ahead and I can, so if you can want to start.
So again, I think I would just go back to, in a perfect world, we could go back and do it all over again and do a much better job. So for us, it was really the learning curve. So in terms of resources, we really tried to standardize, again, our processes and the communication that went out to patients. So I believe there were some information handouts and some certainly around privacy and when we got into emailing and things. So there's some documentation that would come along with that. In terms of accessibility, what was the question around hearing impairment as the example? Again, it's probably on our go forward list. I don't know that we have really gotten into the depth of really truly making it an accessible virtual service.
And I can comment about the hearing, actually the issue with the hearing ability. It is an issue with the phone appointments for sure, and it actually was more evident when one of our family physicians who actually has added competency in care of the elderly, so it was very evident like a lot of his patients he couldn't do phone appointments for. So what he did is like he started doing some home visits for these patients. So like rather than bringing them to the facility, so he would go and see them at home or getting collateral information from the family members or trying to do like a Teams appointment, so those kind of methods to help facilitate. But again, like I think it's about wrapping around the patient. So whatever we do, like we don't want to do it for our comfort. It has to be wrapped around what the patient needs.
Thanks very much, both. I'm just going to pull another question from the chat, and so the question is, any experience with using peripherals to allow deeper engagement and perhaps specialist consults such as remote exams?
So can you say that again?
Yes, I'll repeat the question. It's wondering if you've had experience using peripherals to allow deeper engagement and specialist consults, such as remote exams.
Oh, okay. Yes. So no, actually we haven't like had that experience, unfortunately, so far in our region. Yeah.
Thank you. Charlene, maybe I could turn over to you to share some of your experiences and reflections in your role as Chief Operating Officer in the Northern Region Health Authority.
Thank you. So I just thank you so much, Dr. Singh and Julie, for sharing the experience. And I know at the Health Region, there's always been a desire to look at virtual care, and COVID just put that in fast forward for everybody. So I feel confident and comfortable with the leadership in place that all of these questions that are raised are having becoming part of the thought process, and many have already been a part of that thinking and the going forward and making space. So I feel like being based in reality is so important. So clarifying virtual care is a simple telephone in the North more often than not. And I think that there's work outside of the healthcare system that needs to be done, and hopefully this advancement in virtual care will show the need to fix the infrastructure issues across Northern Canada to be able to increase these opportunities. And as I've lived my entire life in the North, and as a Northerner, there's always a fear of getting less than the South, less than your neighbors, and it's often for good reason, right? It's a lived experience, And so I know as we go forward in moving with virtual care, like the question around how are we educating patients is so key, to know that you start with a telephone call. And when that doctor knows that you need to get in person, you're given an in-person appointment. Or if they need a picture or to be on video, that we go ahead and we do that. So I think really comforting Northerners and Indigenous people and understanding that this is really about enhancing access, enhancing equity, increasing the quality of care, and it also helps support our health system and our health professionals as well to develop their capacity and their understanding. So now that we've kind of been fast forwarded into this learning curve, to now take that time to do all of the things that Julie said, in hindsight, but we're just at the beginning of the journey, so it's really in going forward. And so I would just, anybody who's really working hard at improving virtual care, that they really understand the fears that many Northern and Indigenous people will have in terms of it becoming a second-class service or another way not to invest in the North. And so we really have to keep our eye on that. I feel privileged to see and hear the stories up close and knowing that it does improve health care and it does increase access, but not everybody has the window that I get to look through. So we have to really share that story and share that information. And it, like I had said at the beginning, when you work with a team who's conscious like that, it helps when you're in my role in working with chief and councils and mayor and councils and our Indigenous health entities, that you know what you're saying is genuine and authentic because the team is as well. So I just, maybe I'll leave my reflections there for now. And great questions coming through the chat.
Yeah, thanks so much, Charlene and Julie and Dr. Singh, for sharing your experiences and being honest with us on this rapid change and learning journey. Really appreciate you sharing your reflections and appreciate the good questions coming through the chat that all of us need to be thinking about as we continue on this journey to, first of all, improve care, and virtual being a tool and a mode that care is being delivered in the rapid change towards that. So really appreciate the questions and the discussion and the honest reflections about where we're at and where the things we're thinking about as we go forward. And thanks, Charlene, for your reflections too. So I encourage you to keep sharing your questions, and also folks are popping resources in the chat too, and so that's great as well. Definitely what we're hoping to facilitate here. At this point, we're going to continue our journey, and I'll turn over to Dr. Mendez. So over to you.
Thank you very much, and that was a wonderful segue to my presentation. I just want to, at this time, to acknowledge the work that was done by our team in the East Coast when I started this journey more than a decade ago. And this was done in the small community of Nain in Labrador. And I've seen from the chat that there's some individuals that are from that area of Labrador. And more than a decade ago, when we deployed our first remote presence robotic system in Nain, we learned a lot. We learned a lot from the individuals in Nain in terms of what were the needs in the community, the issues that had to do with what Dr. Singh and his group are already talked about, the technical issues. And we learned more than anything else that virtual care was not about the technology, but it was about relationships. It was about the relationships that you build with your healthcare workers, the individuals that are providing the care. In this case, it was Happy Valley Goose Bay, the emergency room physicians from there. And that the relationships that you establish over time. And I think that is one of the key issues of virtual care, how it will build a relationship between the healthcare providers and the patients as they get their healthcare virtually from individuals that may be thousands of kilometers away or from another jurisdiction. So I just remember that time and the famous robot that was named, that was called Rosie the robot, that became quite known in the northern communities of Labrador. So from the East Coast, I moved to Saskatchewan. And the reason, one of the reasons I moved to Saskatchewan was because I felt that Saskatchewan was the ideal area to scale up our experience that we had in the East Coast with virtual care. As you know, Saskatchewan has a large territorial population extension and a population of about 1.3 million people, but that are in many communities, especially in the north, where communications are very difficult. One statistic that was very interesting to know when I was exploring going to Saskatchewan was that about 35% of the children of Saskatchewan live in communities that are less than 1,000 people. And those communities are usually rural communities that are remote communities. And the transportation rate of these children when they become very sick was very, very high. And of course, in remote indigenous communities, the trauma of taking the children away and bringing them to tertiary care centers was huge. At times, these children would only can come on their own without their parents or without their relatives. So, it was a very big issue. And something that Dr. Singh commented just rang a bell on me as well. When I went to start the remote presence program in Saskatchewan, my colleagues in Saskatoon told me that this was really never going to work because the people from these northern communities love to come to the big city to shop and to go to the mall and go to the movies. And there's nothing really further than the truth. That is a myth that has been propagated. You know, people want to have their care in their own communities, close to relatives, in their own language. I mean, this is a key issue of the cultural safety health care that virtual care may open for our communities. So I am showing you this plane in my slide. The transportation of individuals from remote communities to the big centers in Regina and Saskatoon, especially in the air, costs about $83 million a year for the government of Saskatchewan. And I'm not talking about the federal government that has the investment in terms of transportation for individuals in indigenous communities. One of the issues that you can see very clearly is that if you have your knee surgery in Saskatoon and then you go back to Stony Rapids, which is almost 800 kilometers north from Saskatoon, you may need to come for your post-operative visit. It may take you 3 days to get to Saskatoon to go to the office of the orthopedic surgeon, who will ask you to flex your knee, look at your wound, and then you go home, and that's a 5-minute visit. So the cost of transportation for people that have this type of appointments is huge. But more importantly, of course, is the issue of individuals that are truly sick. A child that has a respiratory illness that is being rushed to the nursing station in Pelican Narrows, Blue. The first thing that the nurses do is they just run to the phone and call for transportation because it's pretty hard to intubate a baby, for example, when there's only nurses there, and children die. So those are these issues that have made this huge gap of inequity in terms of the delivery of the health care to those populations. So when I moved to Saskatoon, we started about 7 years ago a program using technology that is called remote presence technology. And these are examples of some of the machines that we've been using over these few years to provide health care to these remote populations. And somebody was asking about peripheral devices. So the ability of these systems, as you know, in comparison to, for example, FaceTime in your iPhone or just the phone, is that these are devices that are specifically built to provide medical care or health care. And these devices can be operated using a number of peripheral systems such as digital stethoscopes, ophthalmoscopes, otoscopes, electrocardiography, and ultrasonography. So you can really not only see your patient at a distance and talk to that individual, but you can have an examination of that individual and provide an assessment, for example, for triaging a child to one of the centers. The key issue about these devices that you've seen is that they work with regular telecommunications technology, regular Wi-Fi internet. You can use them in your iPhone or your iPad, and they work with regular cell phone communication. The bandwidth, for example, the minimal bandwidth for these devices to operate is about 3 megabytes per second, and which is really 3G connectivity. And that has been really the key issue about this technology, as opposed to the traditional telemedicine technology that has been used for decades. So you can use this, for example, if I get called by a patient, I can just grab my iPhone and connect it to through my cell connectivity and see a patient that is 2,000 kilometers away. And of course, what these also require is that there's at least that amount of connectivity and the bandwidth in these locations. And this is something that I'll be discussing at the end, what are the true barriers in terms of the availability of telecommunications, internet, cell connectivity in the most remote locations. One of the things that we've done in Saskatchewan in terms of the deployment of these remote presence technology is we have done this in a very systematic manner. And these again are lessons from Maine in the East Coast, where we deploy these systems in Cape Breton as well, is that before any of the systems are employed, and this is a photograph of the nurses in the nursing station in Pelican Narrows, which is about 400 kilometers north of Saskatoon, is that we actually have a needs assessment where we really talk to the individuals in the community, the elders, the healthcare workers, the authorities in that community to truly understand what are the needs in that community and what is the best system to deploy to that community. Something that I've learned over the years is that it's not enough just to, for example, put one of these robotic systems there. What is really crucial is that whatever the technology you are using serves the purpose that the community wants in terms of the provision of health care. Technology is only a tool. It is just only an instrument by which you will be able to accomplish the goals of providing timely health care, for example. And in this case, in Pelican Narrows here, what they said was our number one priority is acutely ill children. When you have a baby that is sick, and we need to have somebody to take care of that baby. You can just calling transportation and sending a plane or a helicopter is not enough. That can take hours. to organize. And in the meantime, you have complications and bad outcomes. So for Pelican Narrows, and I'll talk a little bit about the work that we did in Pelican Narrows, was acute pediatric care. So what we did in Saskatchewan in terms of organizing this network, we organized a network where we will have both specialists that were in the tertiary care center, for example, in Saskatoon, and as well working with family physicians that were in more peripheral centers, which will in turn work with even more remote centers where there were not physicians, they were only had nurses and nursing stations. So we have this system by which a family physician, for example, could get a call from a nursing station about, for example, a patient, an elderly patient that was having chest pain and potentially could be having a heart attack. So that individual, that family physician, could actually call a cardiologist in the Royal University Hospital in Saskatoon, who will then patch through this technology and be able to see together with that family physician in Stony Rapids, for example, on a patient in a little community called Pont du Lac. And they could determine could do an electrocardiogram and could determine if that patient needed to be triaged to Saskatoon. So that was the platform upon which we built this system of remote care. In terms of the specific experience, for example, in Pelican Narrows, that is worth commenting. And just by the way, all what I'm telling you in terms of the data that we gather is all published, and hopefully they're going to share the website that we have. Anybody that wants to look at the papers on any of the data that I'm talking during this presentation can go to our website where all the papers are there, and you can download the papers. But for example, in Pelican Narrows, as I told you, one of the issues had to do with acute pediatric care. So we did a study where we compare the town of Pelican Narrows to another northern community that did not have the robot. And we did a head-to-head comparison over a period of about a year. And what we found is that if you had this system deployed in a remote community for acute pediatric care, and where the acuteness was standardized in terms of the CTASC scores, for example, in the community that had the robot, about 65% of the times you can actually take care of the child in their own community, and you did not need to transport that child to Saskatoon. And of course, once you have that, when you could take care of that child in that community and not only do the assessment and do the follow-up, then we looked at what the cost will be. And in a period of about a year, as I said, this program was truly cost-effective because if it could, when you look at the transportation cost, and specifically at the length of stay cost, for example, if you have a child that may need to be transported to Saskatoon, some of the times that transportation is not necessary. You know, it appears that a child needs transportation, but when you arrive to the pediatric intensive care unit and you have an assessment, it may not need to be transported. But whatever the condition is, you don't take that child back and send it back to the plane to that community. These children were admitted, and they're admitted for a period of about 5 days on average. So when you take into account the cost of transportation and the admission rate, you could buy 5 robots in a period of a year just by saving on that. So we demonstrated that in Pelican Narrows, for example, for pediatric acute care, it was not only clinically effective, but also cost efficient as well. So, so this is again the type of program that we have. So we have, for example, the tertiary care hospital in the big city. that can communicate with a rural hospital which may have one of these robotic systems, which in turn can communicate with a remote nursing station that has a less sophisticated but a quite effective system as well. So you can have both specialists as well as family physicians in rural communities taking care of a patient that's really remote. The really interesting thing about this experience is that we started to really build the relationships of the specialists with the family physicians, with the nurses in these remote stations. And it's amazing how our preconceived ideas are from both sides. A specialist really was able to understand what were the resources that were available in the rural hospital and in the remote nursing station, and truly have a context of what the reality was in terms of what was possible and what was not possible. And on the other hand, the ability to have one of the nurses to be able to talk to a cardiologist or a neurologist directly and be able to assess and take care of the patient together as a team allow not only a lot of learning, but one of the things that was unintended in our studies was the improvement in retention and recruitment of nurses. One of the main issues that we found was that why nurses turn around quite quickly in remote locations. It is because they feel that they are not supported, and they are sometimes practicing beyond their scope, and to have the support on real time from your family physician or from your specialist became quite an important thing. So nurses tended to go to the communities where they have the robotic deployment rather than the other communities that didn't have that. So that is something that it was very interesting to see. And of course, the educational aspect became quite an important aspect in terms of what we did. But we were going even beyond this. So one of the issues that we found in terms of deploying this technology was to look at certain services that were truly not available in remote communities that were crucial for the provision of basic primary care. And for example, one of those areas was prenatal ultrasonography. You know, as you know, the pregnancy rate in northern communities is higher, especially in young women. And prenatal ultrasound is a crucial aspect of the prenatal care. And but if you live in northern communities, sometimes it's very hard to have to go all the way to a city to get your prenatal ultrasound. There's issues that have to do with the living, if you have other children, leaving your children away, the cost of transportation, and so forth. So the rate of prenatal ultrasound in some of these northern communities in Saskatchewan was pretty low. And the rate of infant and maternal mortality was relatively high in comparison to the south. So one of the areas that we focused had to do with the provision of robotic ultrasonography. And we deploy 3 systems of a very interesting and innovative technology where the ultrasonographer that is located in Saskatoon can actually do robotic ultrasonography manipulating a robotic arm. And what you see here in the pictures is 2 deployments, one in the town of La Loge and another one in Stony Rapids in northern Saskatchewan. And what you see is this kind of pole where there is this thing hanging on that. And what is hanging on that is the ultrasonography probe. And the only thing that you need is you need somebody to hold this ultrasonography probe on top of the patient's abdomen. And the probe is actually controlled by the ultrasonographer here that you can see is actually controlling this probe totally remotely. And if you go to our website, there's actually a video of how this is done. But this became really a game changer in terms of our ability to provide a remote ultrasonography, and became quite apparent how useful it was as during the COVID pandemic just a few months ago, a few of these communities where they had outbreaks had to actually be locked down, and no people could go back and forth, and we were able to provide ultrasonography care for almost 100 women in this community during the COVID pandemic. So this is the next generation of what is possible using technology, not only being able to talk to the patient, to be able to talk to the nurses, to actually examine the patient with peripheral devices, and now actually doing a whole sonography exam at a distance using this technology. Let me just, okay. So if I can get in, okay, so the next slide, what the next slide shows is that the next step in terms of what we are thinking. Now that we can communicate with a community remotely, now we can potentially examine the patient, we can make a decision about an assessment and the triaging of that patient or maintaining that patient in the community. One of the questions that we were confronting is how do we, for example, send medications and how, for example, we send samples for the laboratory. And this is a big issue, especially in the most remote communities where there's no roads, where everything is through air. In the winter time, it is very hard to get medications and to get samples. So we are exploring this idea of using drones, and these are the drones that are now we're working with a couple of companies that are supplying these drones that could actually fly a pathway from one center to another center. For example, from a regional hospital to a nursing station. And we're trying these drones on the winter time, and we have developed this special system which maintains the temperature of a blood sample, for example, constantly while you have this drone flying during the winter time. So this may be something that could be used in the future, but it's part of the progression of the work that we are doing with virtual care. I just want to, there's a lot of other stuff that you can find in our website, but I just wanted to have a few reflections about what has happened with the COVID and what is the future of virtual care, and specifically what are the barriers. So with COVID-19, there has been something that has been very important, a cultural shift. I've been working on virtual care for more than a decade. It has always been a struggle to especially convince my colleagues that this is worthwhile doing, that actually virtual care is something that is that could be quite effective. It is less difficult to convince our patients. When we did our surveys, for example, of the acceptance of this ultrasonography, over 98% of the patients felt that they rather have a robotic ultrasonography in their community rather than having to travel to do that. So patients will accept technology if it works for them. But during the COVID, there has been the cultural shift in our colleagues, the physicians and healthcare workers, to accept virtual care as something that is actually useful. And of course, there also has been the cultural shift on our patients to accept virtual care as a way to have healthcare delivered to them. And that has advanced the virtual care pathway, I would say, several years in the future, leapfrog into the future. Virtual care is here to stay. It will continue to develop. And some individuals feel that in the next maybe 10 years, 50% of all the interactions between physicians and their patients will be virtual patients. However, the idea, and this is one of the fears, is the face-to-face interaction going to disappear? I don't think that will ever happen. We physicians will use virtual care as another tool to provide care, but also we will value the face-to-face interactions much more. This is part of being what is being a physician, this human-to-human interaction, and will become even more important. So I don't think it will detract from that. And I think that it will never replace the physician. It's going to be just one more tool that will be used to provide care to our patients. An important tool for the remote communities. They really deserve, as any of us, timely care. And timely care is a more effective healthcare. Your outcomes are better. You're able to act in a timely fashion. And I think it may decrease this inequity that we see that is so prevalent, especially with our indigenous populations. We need to advocate for the telecommunications infrastructure to be there. The internet has to be as good 1,000 kilometers north of Saskatoon as is in the city itself. And I think that is a crucially important thing. What will be the barriers? And we're having chipping a little bit of the barriers because of the COVID. One of the big things that we encountered in Saskatchewan was the issue of the remuneration barrier. How would actually you would be remunerated for virtual care? And COVID has improved that. The issue of jurisdictions. As a physician from one province can take care of an individual from another province. So I think these jurisdictional issues need to be worked out. Issues that have to do with the liability, who is responsible for taking care of a patient at a distance, especially as technology continues to improve, we're able to do more and more for the patient. But I feel that the main issue will be the ability to incorporate virtual care into the regular flow of the physician. I feel that this is the most difficult barrier because although people may be using virtual care even from the phone, cell phones, FaceTime to robots now, incorporating them into their workflow will become an issue, and I think that's going to be part of what it has to do. And just my parting comment is that, again, it is not about the technology. It is about the relationships. It is about how you organize the logistics of it. It's about workflow, but it's unstoppable. And I think we need to embrace it now, and we need to advocate for our patients. Thank you.
Thank you so much, Dr. Mendez. Really appreciate you sharing with us your experience and clearly your passion and deep commitment for improving care with and for people in northern and remote areas. I'm just looking at the chat. There are many questions about how, in an environment where we're using virtual technology as a tool, do we support trusting relationships and developing relationships and trusting relationships. So I'll invite panel members to reflect on that. And then there's also some very specific questions as we think about high quality care and culturally appropriate, culturally safe care. Are there opportunities and what are the next steps we need to think about in terms of what that looks like, particularly within a virtual environment? Maybe, Charlene, I could invite you to offer some reflections as part of your role as Chief Indigenous Officer with the Northern Regional Health Authority in Manitoba on those questions.
Absolutely. Thank you. I had just jotted down, it doesn't matter what you're talking about, from robotics to virtual care appointments to, anything. It's all about relationships, and we can't underscore the value of relationships and the time it takes to build them. It isn't something that you can zoom through quickly or check off in a box. It requires constant time and attention, and it has to be seen by the institution, the organizations, and the people within them that relationship building is time well spent. And I just can't underscore the value for those relationships and in anything that we do. And when we talk about how, I did see one of the questions, how do you build those relationships if they're not pre-existing, or if you don't know these patients, how do you do it? And it's just like anything, you just have to take that first step. In the Northern Health Region, just to give an example, through COVID, the first week that Manitoba had a confirmed case as the Northern Health Region, this group has grown a little bit over time, but today there's over 100 of us that get together every Friday and the Northern Health Region shares the public health report, the epidemiology, what our hospital and healthcare capacity is, what services are available, what restrictions exist. We share all that information, and then we allow for a Q&A, and you have mayors and councils, chief and councils, health professionals, all talking and asking questions. And being transparent isn't as easy as it sounds. I'll tell you, at the beginning, it was hard for our team to fully, there was an excitement. I don't want to underplay that. There was an excitement to engage, but a fear. And we just kept doing it. And now it's one of our exciting spaces to be on a Friday after. Well, it's being chaired on my behalf right now, but it's happening in Manitoba. And I think we just need to create space. So whatever your avenue or whatever your work environment is, that you create space for relationship and understanding, and to be really flexible. As a Northerner, again, I've had many people come to us with their ideas that they have, and lots of them good, but they don't always work here. And you spend all your time trying to convince them of what's needed. So if as professionals and leaders, we could come with some ideas, you got to do your homework, but then you have to be willing to listen, shift, and change with the people that you're working with, and not impose your views on them. And really, I had an elder say to me, what's cultural safety anyways? And I said, well, I'm still learning, and it's really about, and I started, and she said, is it just a way of not being racist, a way of saying don't be racist? And I said, well, I mean, if you want to simplify the term, yeah, I think you've kind of nailed it. So I think when we talk about cultural safety, that we acknowledge the biases that we have, that we check ourselves, and we ask those around us that we care and love or have respect for to also put us into check if we're moving too far along one time. So I think there's some really individual things that we have to do, but then there's also, it needs to be in tandem with our organizations and with the leadership within those organizations. So what can you do from yourself, I think, is where you start, and then it keeps growing. But yeah, not to underestimate the value of relationships and the many wins that can come out of it. And just listening to Dr. Mendez's passion and lessons learned, I just want to keep cheering along as I was listening to the lessons that he's learned, because if people can start on that space and that mindset, wow, virtual care will explode in a culturally safe, equitable, and accessible way. So I'll leave my reflections there. Thank you, Maria.
Thanks so much, Charlene. I'm aware our time together today is rapidly coming to an end. Maybe I'll invite Julie or Dr. Singh if there's any other reflections that you'd like to share as we're about to wrap up our time, either using your audio and or in the chat. And while you're giving that a moment to think about, just want to point folks in response to some of the questions about the specific technology that Dr. Mendez was talking about. We did provide some links to some articles and papers in the chat if you want to scroll up. But that was from Megan Sabian on our team at CSHI. So thanks, Megan, for sharing that. I'm just going to take a huge moment because I can see some folks are starting to need to exit to get to the next places they need to be top of the hour. For a huge, huge thank you to Dr. Singh, to Julie, Dr. Mendez, and Charlene for joining us today. We're going to pop up a quick survey because we really do look to what folks who are able to join us on these webinars tell us about what's helpful or what's interesting, what they're thinking about, what would be helpful to facilitate a virtual discussion on. So please take a moment to answer those 4 questions. They really do shape the what's next for us. I want to quickly mention as well, just building, Charlene, on your comment about cultural safety and, racism in our health systems. Certainly, recent events, not new, but recent events that have been very publicized, including but not limited to the death of Joyce Echaquan in a Quebec hospital, very publicized, and a recent report from British Columbia in plain sight, led by Mary Ellen Turpel-Lafond and team. We will be hosting next week, that's February 4th, a virtual discussion where Mary Ellen and team and Dr. Darlene Kitty, the former president of the Indigenous Physicians Association of Canada, will be joining us to talk about exactly that, Charlene, understanding that racism exists in our health systems across the country, and how do we better understand where it exists, how do we respond to that. So a difficult but really important patient safety and quality issue that will be creating some space for some conversations with health system leaders next week, and we'll put the link to that in the website as well. While people are filling out the chat, I'm just going to invite Julie or Dr. Singh if there's any other reflections you'd like to share just in maybe in a minute or so.
I would just like to say thank you again, and I always feel a little bit guilty for these opportunities to be able to share our story, but there's always so much in return. So I think the opportunity to work with CFHI again is always wonderful. But I'm looking at the chat and looking at the questions and the comments and the resources that have been offered. I just wish we had so much more time to really dig in. We're really at the infancy and start of our journey, and listening to Dr. Mendez and his experience in this area is just very exciting for what we can do. And again, just the commentary in the chat box of everyone who's been here today is just lots of food for thought for us. I'm really grateful.
So thanks again for the great day, and with all the presentation, Dr. Mendez's presentation was really fantastic. So I just want to mention only one thing, and I've actually written it in the chat box as well, but I just want to emphasize that the virtual care is the future. Like Dr. Mendez said, 50% of care will be virtual, even if COVID is gone. So we need to have all those technologies available, but we do need bandwidth to support those technologies. So I think this is a big advocacy that's needed for the government, that this should be the priority, that they should invest in having a Wi-Fi or a 5G or something available in all the north. And actually the cost savings will reflect, as Dr. Mendez mentioned in his presentation, the cost savings of not sending those kids to the hospitals, it pays off really fast. So this will be a very useful investment. I think that's kind of my biggest takeaway from the day-to-day actually. Thanks.
Thank you so much, everyone, and thank you again for everyone who joined us and shared really good questions. We didn't have a chance to get to all of them, but I think this series may grow. So thank you for sharing those, and we will look for opportunities to continue the discussion. Thanks, too, for sharing your resources. That really makes us just that opportunity to exchange what's working, what we're developing, what we need to be thinking about next, and certainly lots of points just to echo them. That your comment, Doctor, is in terms of the importance of broadband for this as well. So some next steps and calls to action going forward. Thank you to everyone for joining us today. This concludes our event. A reminder that the session was recorded and will be made available on our website. And so you're welcome to reach out to us with suggestions or feedback. Please share broadly within your networks the resources that you learned about. And just wishing everyone a good rest of the day and to stay safe and healthy and hopeful. Bye for now.
This concludes today's webinar. Thank you, everyone. You may now disconnect.